The hypoxia itself does eventually lead to breaking a spasm because the hypoxia causes the muscles itself to become hypoxic and they naturally will break the spasm. Now, not super ideal to like watch someone turn purple before your eyes before you can actually ventilate them, but I actually have seen that work. And again, it's more torture to watch it, but I would equally be 100% ready to go to either do an IM sucks or IV sucks, whatever. If you don't have an IV, you would be ready to go with that at any given moment to break it and not obviously let them decompensate with their heart rate and things of that nature. Hey, future CRNA. So a quick disclaimer, because in today's episode, we're doing a little more clinically based type of topic. And I want to make sure I'm throwing it out there to make sure you're always fact checking me and to make sure that you're equally looking up the doses of medications prior to actually administering any drugs. So I hope you guys enjoyed today's episode and let's get into the show. What is the difference between a laryngospasm and a bronchospasm? In today's episode, we're going to start doing something new, which is our quick hits anatomy, pathophysiology, and pharmacology sessions. So I hope you guys enjoy. Let's get into today's show. Hello, everyone. Welcome back to CRNA's Prep Academy podcast. I'm your host, Jenny Finnell, CRNA, and today marks a brand new series that we are starting to do, which is kind of an anatomy, pathophysiology, pharmacology quick hit session where I pick just a really singular topic and then we discuss it in detail. So in today's episode, we're going to talk about the difference between a laryngospasm and a bronchospasm. So if you are just starting your CRNA journey, whether you're still in the ICU or whether you're getting ready to start your program, I think it's fun to know this knowledge because it's only going to help you in the long run. And the sooner you kind of can learn how to differentiate between a laryngospasm and bronchospasm, the better off you're going to be once you enter into your clinical round of training. So let's kind of get into some of the basics. So a laryngospasm is an upper airway spasm. So again, it's when your vocal cords are completely shut. It is a muscular spasm of your vocal cords, okay? So you can have a complete or an incomplete closure, so an incomplete laryngospasm or a complete laryngospasm. And again, kind of how you know whether one's complete or incomplete is really based on the symptoms. So if you have an incomplete laryngospasm, you will still hear air movement. It's because the air is going to still be moving through the vocal cords. So you're going to hear kind of like a cooing or kind of like a humming sound coming from their vocal cords. That's an incomplete spasm. That's ideal. That means an incomplete spasm is one that is relatively easily broken with some positive pressure. And usually around 20 centimeters of water, 30 centimeters of water is enough to break that type of a spasm. Now, keep in mind if you're going over 20 centimeters of water of pressure on your ambu bag, right? So your pop-off valve, you close it to 30 centimeters of water. If you're going much higher than that, keep in mind that you're going to be blowing air into the stomach, which also equally can set your patient up for aspiration once you do regain air movement. However, I have my own experience, I have seen more than 20 centimeters needed to break a partial laryngospasm. Usually 30 seems to be kind of a sweet spot for that. But again, you can usually get some air movement. You're going to see some end tidal CO2 in a partial laryngospasm. You're going to hear air movement. Again, I love hearing those sounds because that means that I'm still moving some air. But it's really critical that you take steps to break it. And so other than positive pressure, some of the reasons why they would be spasming at this point is because of secretions that are on their vocal cords and they're also light. And when I say light, that means on a light plane of anesthesia. So most laryngospasms will happen with either induction or emergence, but I would say most commonly it's almost always emergence because usually induction, you're in the process of getting them deeper. However, that being said, in pediatric anesthesia, when you're doing just inhalation induction, if you break a seal during the inhalation induction and they kind of go through this really, really prolonged stage 2, you equally can really risk a spasm during that time. So again, I would say in adults, you're typically giving IV medications. The risk of laryngospasming at that point is relatively low considering you're giving propofol via IV and then paralytic if necessary. But usually the propofol is enough to get you deep to get you through that stage 2. You also equally can mask an adult down with some gas as you're giving the propofol. But again, in a pediatric induction, you don't have an IV. So you rely heavily on your gas. And for those of you who haven't embarked on your pediatric rotation, especially for like the bigger peds, ideally, we would want the bigger peds to get an IV, right? But sometimes it doesn't always work out, or sometimes you have a child who is morbidly obese, and so you're putting someone with a body habitus of an adult to sleep with no IV. And what I will say from experience is that stage 2 can be very violent to mask someone through stage 2. Their body usually heaves up and down off the bed. They get really squirrely and squirmy. They want to throw their head back and forth. You kind of have to anchor your elbows to the bed with the face mask on, and then kind of go with them and just make sure you're keeping a good seal. That is key for a pediatric induction or any inhalation induction, is to make sure you're keeping that seal. Because again, if you break the seal at any given time, they're going to lighten back up very quickly, and you're just going to prolong the stage 2 and equally risk spasm. Because at that point, if they have some secretions around their cords, and let's just face it, if you have to slam a face mask on a crying baby, they're usually really snotty and goobery at that point because they're not happy. So you do have a high risk of laryngospasm with secretions. So typically, in most cases, when you're emerging, and let's just say you're taking an endotracheal tube out, they show signs of life, right? They're awake, they're kind of opening their eyes, they look like they're maybe ready to be extubating, you decide to take the tube. Well, maybe they were kind of like not quite through the stage 2, and you pulled it at an inopportune time to where they're still kind of in that stage 2, or maybe their eyes are a little still disconjugate. Maybe so usually when you enter stage 2, you're going to see the heart rate increase pretty acutely. So maybe if their heart rate was maybe 90 during emergence, maybe now it's going to jump up to the 110, 115. That's usually a sign of entering that stage 2 of more excitement. Also look at their pupils, like I said, if they're disconjugate, meaning looking away at, one's looking at the right corner of the room and one's looking at the left corner of the room. That means don't pull. That means give them some time until their pupils become midline, until they look like they're actually looking straight ahead versus 2 different directions. But whatever, what if you make a mistake, you pull it, you know, we all make that mistake. It will all happen. And you get the tube out and you go to put the mask on their face, and you have one or two things happen. Either you hear no air movement, and initially you're like, oh, maybe, and you're looking for fog in the mask, and you're like, oh, okay, maybe they're moving. You see their chest rising, but then you realize pretty quickly that, yeah, their chest is rising, but I don't have end tidal CO2, and you see their suprasternal notch going like this. And if you're on YouTube, you can see it, but if you're on the podcast, use your imagination. But if you put your finger at the base of your neck where it kind of indents a little bit and you suck in, you'll feel that kind of depress. So if you have a complete spasm, you will see that suprasternal notch kind of be sucked in. You'll also kind of see their chest heave at the same time. That's a complete spasm. That means no air is being moved. That means you're not getting end tidal CO2. It means like if you try to mask, you're trying to mask a brick wall. Again, that's a complete laryngospasm and something that should be taken very seriously, and actions to be taken to break it. So we'll get into that in a little bit, but just to kind of recap a little bit, a complete spasm, if the same situation were to happen and you were to take the tube out, kind of what I see also, I should preference, what I always see kind of coincide with a laryngospasm, like 9 times out of 10. It just always seems to be 9 times out of 10, this is what happens. They cough. So, and it's usually because there's secretions on their cords and it causes them to cough, but that cough is like an instant signal spasm. So if you ever, and I know you want coughing to happen with extubation, but if you extubate someone and they're relatively, relatively like, so you extubate, the first thing they do is they take a cough or something like that. You should always confirm that they've now can fully exhale from that cough. If they don't, be really suspicious of now that's a laryngospasm. Coughing tends to coincide with laryngospasm during emergence, and sometimes it's kind of like to be expected, right? Because you're taking a tube out, they're coughing. But unless they're fully awake, that cough could equally trigger that laryngospasm. So just keep that in mind. It always seems to be the case where I hear that cough and it's just like, boom, laryngospasm. So keep your guard up on that. But let's just say you take the tube and you have a partial laryngospasm, you can hear air movement, you can hear kind of a cooing through the cords. Again, keep the positive pressure on, and usually that's all you have to do to break that. Now, you can always give some propofol, IV lidocaine, things like that, to kind of help speed the process of that, to kind of deepen them up a little bit to get them through. But again, usually positive pressure with that type of partial laryngospasm, and also suctioning to make sure you're getting secretions out from the back of the throat is usually all you need to do to break those types of spasms. Okay, so a total spasm means there's no air movement. And again, you want to make sure with any type of laryngospasm, whether that's partial or complete, you want 100% O2. Now, typically, if you're inducing or you're emerging, you're going to have 100% O2. Hopefully that's kind of the standard, but I want to make sure I mention that it's important to make sure you're giving 100% O2. This is equally why it's important when you are emerging someone under anesthesia that you pre-oxygenate them with 100% O2 to where their end tidal CO2 or their end tidal O2 is above 85%. Again, as close as that number or higher if possible, if you can get it up that high. All too often, I'll see trainees, students, and RRNAs not pre-oxygenate quick enough at the end. They literally might be getting ready to pull the tube and then they put them on 100%. So the patient's only going to get like a few breaths of 100% and then they're going to want to take the tube out. I think that's a big mistake. I think you need to be thinking through that ahead of time and really making sure you're tanking them up. Because again, if they do spasm and a complete spasm, now you're working with time, right? You have time before they desat, get hypoxic and things of that nature. So you'll buy yourself more time if you pre-oxygenate the patient really well. So just something to keep in mind. But again, you want to keep continuous pressure on them. Typically, they say not more than 20 centimeters. However, in my personal experience, sometimes it's a little bit more is required to break a total spasm, a complete spasm. But you want to turn your APL valve or your pop-off valve to 20 centimeters of water and just really provide a continuous positive pressure. And keep in mind, you need to have a good seal on the mask in order to do that. This is also why when you're emerging someone from anesthesia, you need to start thinking, were they easy to mask? Did I require an oral airway? Don't be afraid to make sure you secure that oral airway as you take the tube out, which is why it's nice to have one in before you extubate for a couple of reasons. One, because now you can easily mask them, shall that arise. And two, it prevents them from biting on their endotracheal tube and causing kind of like a reverse laryngospasm where they're actually obstructing their airway because they're biting on the tube and now you can't ventilate them, which is no fun. We can talk about it in another episode, but again, that can happen. The downsides of using an oral airway is the secretions, because if you don't do a good job at removing oral secretions prior to extubation, that oral airway can just trickle it back right onto the cords, right? So it can also equally be setting you up. You can get around that by just doing a good oral suction. And some of the mistake I see made early on, including myself, was when you go to suction, you're kind of just gently suctioning, you're kind of hitting the back or roof of the mouth, and sometimes that can even cause the roof of the mouth to bleed. You really want to be kind of going for the gutters and twisting the Yankauer as you go in, so the end of the Yankauer tip kind of goes along with the airway, meaning like almost act like you're intubating the patient with the Yankauer. And that's again going to follow the path of the tube and where the airway structures are to really get the secretions that are pulling the back of the airway and the throat. So that's, if you do good suctioning like that, you will make sure that you can combat this problem as much as possible prior to taking the tube. Now, depending on the type of case you're doing, type of surgery, that type of thing, maybe there's blood. Maybe there's just a lot of trickling blood. And those are always higher risk extubations because of that reason. And so sometimes the technique you'll see done is maybe you'll aggressively suction as best you can. Some surgeons are like, don't suction because they're paranoid about their suture lines and don't want to cause a major bleed. So you can use like little tiny soft suction catheters, or have the surgeon aggressively suction before they come out of the oral, before they're done operating, make them do the aggressive suctioning so they can make sure that they do it the way that feels good for them. But ultimately, you can't be afraid to suction the patient more if need be. And you can use a little tiny fine tip. And again, another thing that technique that we do is when you're actually extubating. Now, the key to doing putting suction to your endotracheal tube during extubation is to not do it too soon. If you do it before you come through the cords, kind of picture in your mind what you're going to do to the lungs. You're going to collapse the lungs and cause massive atelectasis right before extubation. Not ideal. So again, and this is where it kind of comes into play of kind of knowing your anatomy and kind of like the depth that it takes for the endotracheal tube to come out of the cords of being the oral pharynx, and you kind of get a feel for that. And then pay attention to the length it is. Pay attention when you're putting the tube in, when you're just staring at endotracheal tube, the distance, right, between taking the tube out and when it would come through the cords, the cuff come through the cords. But essentially, as you're taking the tube out, you kind of want to gauge when you think that moment would be. And actually, you can kind of feel it. If you get inclined with, you'll eventually develop a feel for what it feels like to come through the cords. And that's when you stick the suction on, you rip it the rest of the way out. It'll get all the goop that's kind of piled up back there. And that way, you can avoid or decrease the risk of laryngospasm at that point. Hey future CRNA, another daily dose of inspiration from a CRNA School Prep Academy student. After 3 years of applying and a lot of rejections, I finally got an acceptance letter to one of my top choice schools. Coming from a background of being told and treated like I'm not good enough for most of my life, the mental gymnastics I had to do was real. For the past 3 years, I have purposely been putting myself in a position to be told I'm not good enough. And I was told that many, many times. The difference is, since becoming a nurse, I know that I am good enough. My socioeconomical and educational background was not so great growing up, and nursing was my second career. When I was younger, I lacked confidence in my educational capabilities as a young adult, and it was not until I went back for nursing that I realized I could be smart enough. I wrecked my GPA when I was younger, so I had to work hard to correct it. I did that in nursing school with my BSN, but I had to be extra aware of what programs use the last 60 credits or nursing degree calculations. Despite having 6 years of ICU experience and 10 years overall, I had to return to the ICU to gain recent experience, which when you have a cushy IR cath lab position was no easy task. But I can say now that it was worth it. I'm going to do this and I cannot wait to get started. I would like to thank CRNA School Prep Academy and all the resources and support that is available. Thank you, Jenny and Richard, and everyone else for making our dreams a possibility. Start date, June of 2023. CRNA signing out. Congratulations, CSPA student. If you're listening, I know who you are. I'm so incredibly proud of you. I know you've been at this for a long time. So those of you listening to this story, if you can relate to the feelings of not being good enough, I hope this story hit home. And let me remind you that you are too capable of achieving your dream of becoming a CRNA. If you're not already signed up for our free Future CRNA newsletter, be sure to do so now. Pause this episode and go click the link in the show notes in the comments below. Cheers to your future. I'm rooting for you. Now let's get back to the show. So ultimately though, if you're doing positive pressure and it's a complete spasm, they're starting to desat, at this point you're trying to deepen them back up. You can give some propofol. Again, IV lidocaine, although I've personally never seen IV lidocaine break a true complete spasm, but it still is listed in potential toolbox things you can use. I think propofol really is the best drug of choice to really break a spasm. So again, that would be the drug of choice that I would go for first. Now, obviously, the succinylcholine is like the gold standard, right? If you have a complete spasm and they're desatting, they're turning purple on you, you can't break the spasm. I've seen and heard different rules of thought, so I'm going to share them both. And I'm saying this just open-endedly what I've seen in practice. The hypoxia itself does eventually lead to breaking a spasm because the hypoxia causes the muscles itself to become hypoxic and they naturally will break the spasm. Now, not super ideal to watch someone turn purple before your eyes before you can actually ventilate them, but I actually have seen that work. And again, it's more torture to watch it, but I would equally be 100% ready to go to either do an IM sucks or IV sucks, whatever. If you don't have an IV, you would be ready to go with that at any given moment to break it and not obviously let them decompensate with their heart rate and things of that nature. Now, depending on the patient, the health of the patient, whether they're a pediatric patient, adult patient, cardiac patient, whatever they are, you have to kind of use your best judgment on how far you would take before you break it, and obviously how low you let them go stat-wise. You want to always keep the patient's ultimate safety and recovery in mind. So again, there's no set number to magically just then give sucks. I wish I could say when they get to 70% O2, that's when you give sucks. It doesn't work that way. Because typically, again, you're giving propofol, and as long as you stay consistent with the positive pressure, and if it requires a 2-hand mask jaw thrust, you're putting pressure on the back of their jaw. I very rarely have seen succinylcholine needed to be given with that type of aggressive resuscitation from a complete laryngospasm. I have seen it given. The problem with succinylcholine, especially after the end of a case where you have given neostigmine and Robenal to reverse the paralytic, is that now the succinylcholine will make the patient even more weak. So if you're going to give, say, a 20 milligram dose of succinylcholine for a complete spasm that will not break, and you've already reversed with neostigmine and Robenal, well, you better be prepared for the patient to have actually muscle weakness at this point and probably need support and possibly a BiPAP machine until they can fully recover and pack you. So it does kind of complicate the recovery process a little bit, but obviously it is what you have to do. 9 times out of 10, you can usually break a full spasm with aggressive propofol treatment and positive pressure. But again, in a partial spasm, usually it can break with just some aggressive positive pressure with plus or minus propofol. It's never wrong to give propofol, but you will always need it for a total spasm, always. And sometimes, you can even turn your gas back on too. Just try to get them deep, get them through that. Here's where it kind of gets where like laryngospasm, bronchospasm, we're going to kind of get into it because I think sometimes it can be kind of confusing as what you're actually dealing with between a bronchospasm and a laryngospasm. So let's go into bronchospasm. All right, so as we mentioned with laryngospasm is upper airway, bronchospasm is lower airway. So people who tend to have bronchospasm, here's a big one, you guys. Write this down. Every time this happens, I'm like, I knew it. So ask your patient if they've had a recent upper respiratory infection, meaning a cold. Have you had a cold in the last 1 to 2 weeks? I don't care if it was 2 weeks ago. They could still have some remnants from that cold. And that's a really big red flag that they're a higher risk for bronchospasm, okay? Always, which is also equally why if they actively have a upper respiratory infection, we don't do anesthesia. We've canceled cases for that before. So, but again, sometimes patients are like, yeah, I've had the sniffles or I've had a little cough, but I'm fine, but they're always a little bit still more irritated down there. And so they always are a little bit higher risk. So kind of be on high alert, high guard. And it never hurts to give those types of patients a nebulizing treatment or some albuterol, make them take some puffs of albuterol before they go to sleep. That's never a bad idea to do that as a preventative measure. But again, it's a lower airway, involuntary contraction of the bronchial tree. So what you'll notice is inability to ventilate in the absence of upper airway obstruction. Well, if you only had x-ray vision, right? Sometimes when you see the symptoms of a bronchospasm, depending on where you're at in the case, it can be pretty apparent it's a bronchospasm, right? Meaning, if they're already intubated, you have a secured airway, and maybe the surgeon makes incision and you think you have them deep enough, and now you lose end-tidal CO2. Okay, the tube's not kinked. Well, that's probably a bronchospasm, right? I've seen that happen where just that little bit of stimulation in the beginning, if they're not quite deep enough, and deep enough to not remember, I'm not saying awake, but I'm saying there's different types of levels of anesthesia you can have. And sometimes when you have higher levels of anesthesia, you have no blood pressure. So typically in the beginning, you might just kind of get by with amnesia, right? No memory. But maybe that's not ready for surgical stimulation, and they can trigger a bronchospasm from that stimulation. And so again, that's pretty easy. That's a pretty easy way to say, okay, I know what this is. I have a secured airway. We were making end-tidal CO2. Now we're not. Now they're tachycardic. Now they're reacting. It's a clear bronchospasm, right? It's a pretty clear picture of what's going on. It doesn't always tend to be that clear. Typically when it can be kind of less clear is when it happens during induction or emergence. Now during induction, again, it can be similar with a laryngospasm, kind of just them going through a stage 2 and kind of being a little more agitated. If someone's already more prone to asthma and things of that nature, they're more likely to experience this. But keep in mind that anesthetic gases themselves are a bronchodilator. So while it can happen during induction, it's not as common as it is to happen during emergence when you're actually taking away the bronchodilator, which is the gas. So again, it's way more common. But again, induction is actually one of the things that would be the biggest red flag if it happened during induction is thinking about allergies. A lot of times patients roll back in the room with a bag of antibiotics up and ready, but not started yet. And what do? You wide open the antibiotics when they come back, and then you start your induction. If they all of a sudden have a bronchospasm, you need to immediately think and rule out, is this anaphylaxis? Are they having a reaction to the antibiotic? Rocuronium has also been known to be a trigger for anaphylaxis. So again, think about, is there any causative agents that could be triggering this other than just the fact that they're light and they're having a bronchospasm? This is an allergic reaction. The patient's going to sound wheezy. Depending on how severe the bronchospasm is, you're going to hear a lot of wheezes. Sometimes it's if you try to bag someone who is intubated with a bronchospasm, it's going to feel like a brick wall. Even though you're going to have access to their lungs, a direct pathway, it's going to feel stiff. You're not going to be able to move anything. It's really impressive how stiff your lungs can actually become with a really severe bronchospasm. You will not have any end tidal or very, very little end tidal. You will see the shark fin on your end tidal CO2 if you're lucky enough to get end tidal CO2. Where this kind of becomes a problem during induction is because you're trying to rule out are we through the cords or did we intubate the goose, the esophagus? The key differential between the two is if you're really in the esophagus, you typically, if you have enough pressure on your pop-off valve and you try to give a big breath, because the esophagus is more compliant and pliable, you're going to hear kind of like a farting noise, like a like a little bit of a farting noise, or the goose honk or whatever you want to call it. You're just going to hear it. You don't always, but you do sometimes. You will also see the end tidal, depending on how long you mask the patient. Keep in mind, when you mask the patient, even if you don't go above 20 centimeters of water, you will still blow some air into the stomach. And so when you tube the goose, the esophagus, you will still see a little bit of end tidal on your tracing, but it will never rise. It'll in fact get lower and lower until it's non-existent. That's a very good indicator that you've tubed the goose. But if you're like, man, what if this is a bronchospasm? Well, like I said, bronchospasms feel hard as a rock to ventilate. And when you're pushing air into the stomach, it won't feel hard as a rock, So that's one thing to kind of ask yourself. What does it feel like to try to ventilate this situation? And also, did you see it go through the cords? I unfortunately have seen bronchospasms where the assumption was we didn't tube the right hole and the tube's removed and it's truly a bronchospasm, and now we don't have an airway and we have a bronchospasm and we're trying to mask them through it. And that's really no fun, and even, more scary. So again, that's why I want to make sure I'm pointing this out to you when you have to rule out a differential, like did you tube the goose or are we experiencing a bronchospasm? One thing that can trigger a bronchospasm after intubation is when you stick the tube in too far and you tickle the carina. It's like right where the bronchus kind of splits a little bit. There's something called a little carina, and again, Google it to get your imagery. But if you tickle the carina, you can trigger a massive bronchospasm. So this is more common in peds because peds airways are so shallow, and I think especially for people who are not used to it, you don't have to go in that far. And I think with adults, you're so used to just shoving the tube in there and right main stemming. No, I'm just kidding. But you're used to a much bigger tube, and so peds also tend to have more irritable airways in general. But if you stick the tube in too far, whether you're in a ped or an adult, you would risk tickling the carina and causing a bronchospasm. So really, the key to avoiding this is to be cognizant with how far down you're putting the tube and visually watch that tube go through the cords. And once you see that cuff, that balloon completely pass through the cords, stop. That's the simplest way. But that being said, when you're kind of under pressure and you're new at doing it, sometimes you have so much going on that you're like, I don't remember where it was. I think I did it all the way. I don't remember. I was putting a little bit more. I get it because I've been there too. I'm speaking from experience on going in too far. But really, if you can train yourself to pay attention to watching that cuff, you can never really go wrong. And also equally, if you start peds, again, there's formulas to kind of figure out how deep to go, and you definitely need to be doing those calculations. But typically in adults, you typically just, 21, 22, right? 21 for female, 22 for male. You typically kind of follow those standards. Maybe for a taller person, maybe you go to 23, at the lip. So again, unfortunately with adults, you kind of get really in the mindset of cookie cutter kind of thing with length, but know that doesn't always apply. You still have to be cognizant of how far down you're sticking that tube. I challenge you to start paying attention to that if you're in clinical, and you'd be surprised. Some people, you might just hit 20 and you're through the cords all the way at 20. And you might be tempted to go to 22, but technically if you go to 22, you could then tickle the carina, right? So pay attention to that. See if it's enlightening or not. Okay, so now we've just explained the differences between laryngospasm and bronchospasm. Let's go over into the treatments of bronchospasm. So similar to laryngospasm, it's 100% O2. And then deepening the anesthesia, like I spoke to, that gas is a bronchodilator, giving propofol, and then kind of trying to rule out, was this anaphylaxis? Now, I have seen one so severe that nothing else worked other than epi. Epi is like the gold standard for breaking any kind of anaphylactic shock or anaphylaxis bronchospasm. So, but I've seen things like ketamine tried even in that scenario. We're like, well, ketamine's a bronchodilator, but epi was the only thing, and it ended up being a reaction to the vancomycin that was started at the beginning of the case. Obviously, nebulizing treatments, which is the beauty of having a tube, which is why I spoke to when you've removed a tube and now you're mass ventilating, you don't have an airway, your chances of getting a good contact with albuterol or any kind of bronchodilator is pretty slim to none. So that's why it's so important to kind of differentiate before you yank that tube, whether you saw it go through the cords and whether you know for sure it's in the cords and you just have a bad bronchospasm, because then you can treat it with bronchodilators like albuterol and things like that. Steroids and things like that are also treatments. Again, trying to rule out what caused this, but really deepening the anesthetic plane. If you have to, last resort, give epi to break it. But really deepening the anesthetic and giving albuterol are usually the two key things to really break a bronchospasm. So I hope you guys enjoyed. That's kind of, I know it was kind of an abrupt ending, but I hope that gives you a better understanding of the difference between a laryngospasm and a bronchospasm. Thank you so much for tuning in. I appreciate you. Be sure to make sure you rate this on your favorite platform. I appreciate all the love and feedback you give. Until next week, stay strong, future CRNA. All right, bye-bye.
Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.